was Ridley-Joplin classification, Madrid classification and Indian classification. What is the utility of classifying leprosy? Why we are reading the classifications? Classified and tuberculoid leprosy. And finally the Indian classification, lepromatous type, borderline, indeterminate, pure neuritic type and tuberculoid type. I mean in the last pure neuritic type, sometimes it comes as a short note. Pure neuritic type is only seen in Indian subcontinent. Pure neuritic type is not accepted worldwide. It is the classification of Indian classification, pure neuritic type of leprosy. So what is lepromatous type? One is borderline type and another is indeterminate type and tuberculoid type. This is the classification by WHO and we treat it is so 1 to 5 skin lesion, no nerve involvement. Slit skin smear is not always negative, but it's usually negative. So 1 to 5 skin lesion, no nerve involvement, and slit skin smear negative for the lepra bacilli. Multibacillary, more than 5 skin lesion, nerve involvement, neuritis, slit skin smear is positive for lepra bacilli. This is the simplest classification WHO has come out, the paucibacillary and multibacillary leprosy. Now, what is the difference between lepromatous and tuberculoid leprosy? These are the two extreme form of classification. One is lepromatous type, one is tuberculoid type. So, what would be the more common? The lepromatous type is multibacillary, tuberculoid type is paucibacillary. It is bacteriological index. When you will read the lab diagnosis, you will go through the bacteriological index. Now, difference is skin lesion. Skin lesion is many. Multiple skin lesion is lepromatous type and they have a symmetrical margin. Symmetrical margin where tuberculoid has an asymmetrical margin, few lesion. Asymmetrical. Next is the lesion appear as hypopigmented annular macule in case of tuberculoid type and it is elevated border towards the central clearing. So when it is a tuberculoid type, there we will get hypopigmented. There is a loss of skin pigmentation along with anesthesia of that part of the skin, but the margins are not symmetrical, margins are asymmetrical. But in lepromatous type, there are multiple nodules, maybe plaques and xanthoma-like papule, and leonine face and eyebrow alopecia. These are the few findings of lepromatous type. Next we go to the nerve lesion. The main involvement of the leprosy is involvement of the nerve. So nerve lesions appear late and hypoesthesia is a late sign for case of lepromatous type. But in tuberculoid leprosy, early anesthetic skin lesion, enlarged thickened nerve and nerve abscess can be seen. CMI, cell-mediated immunity. Cell-mediated immunity is low in case of lepromatous type. Cell-mediated immunity is normal in case of tuberculoid type. So, how we test the cell-mediated immunity? We test by doing the lepramine test. So, lepramine test is negative in case of lepromatous type, but it is positive in case of tuberculoid type. Humoral immunity. What is humoral immunity? What do you mean by humoral immunity? You already have completed immunology. What is humoral immunity? Humoral immunity is production of antibody. For the controlling of lesion in lepromatous leprosy, humoral immunity probably has no role because lepra bacilli is an intracellular organism. As is an intracellular organism, there is very small role of humoral immunity for the cure of leprosy or the treatment. So, CMI, cell-mediated immunity, is the most important part in case of leprosy. That's why the prognosis of treatment is better in tuberculoid type, it is worse in lepromatous type. Macrophage, if you go for the histopathological sign, there will be foamy type of macrophage, and in tubercular that will be epithelioid type. Langerhans giant cell is not seen in lepromatous type, it is seen in tubercular type. This is one of the lesions of the, you see the A, nodular lesion of lepromatous leprosy and hypopigmented skin lesion of tubercular leprosy. So tubercular leprosy will be presented as hypopigmented and hypoanesthetic patch, tubercular lesion, and if nodular lesion, if it is diagnosed late, the lepromatous leprosy can present with this nodular lesion. It already we have covered. Now, if a short, just recapitulate what is lepromatous leprosy. It is a multibacillary disease. It is skin lesion and many and with symmetrical and irregular margin, and nerve lesion involvement occurs late, and CMI of the lepromatous patient is grossly impaired. Humoral immunity is exaggerated. Bacilli invade the nasal mucosa and shed in large number. So, which type of lepromatous patient is more infectious? Lepromatous type of leprosy, the patients having lepromatous type of leprosy are more infectious than tubercular type. Prognosis, lepromatous leprosy patients have a poor prognosis. Why? Because CMI is low. CMI is most important in containing leprosy, not the antibody or humoral response. Tuberculoid paucibacillary disease, bacilli are scanty, skin lesions are few, but the margins are asymmetric but sharply demarcated. Nerve involvement occurs early. Nerves are often enlarged and thickened. Nerve abscess may be seen and CMI is adequate. Now, I have not made a slide of pure neuritic type. Please write what are the pure neuritic type. It is only present in Indian subcontinent first. Second part, it is only nerve involvement is there, no hypoanesthetic patch in pure neuritic type of leprosy. Third is, which is the commonest nerve involved? In pure neuritic type, it is the ulnar nerve. Ulnar nerve is the commonest nerve that is involved in the pure neuritic type. Next common is popliteal nerve. So, pure neuritic type next. Here CMI is good. So, lepromin test will be positive, and there may be how it presents. Patient may not present with hypoanesthesia or sensory neural loss. Patient may have come to you with a complaint of thickened nerve. You can palpate the ulnar nerve here. If you palpate the ulnar nerve, you will see the thickened ulnar nerve. That is the initial manifestation of pure neuritic type of leprosy. And on histopathology, the features are more towards tuberculoid type of leprosy. So, in pure neuritic type, no skin lesion, only nerve involvement along with the sensory neural loss. There may be autonomic neuropathy. Next, it is most common in the Indian subcontinent and the prognosis is good, but residual abnormality may remain there. So, without skin involvement in pure neuritic type. So, this is pure neuritic type I have already described, because that can come as short note, pure neuritic type. Now, immune response. So, what are the immune response? Innate immunity is very high. So, minority of the people who are exposed to leprosy will develop the disease. So, innate immunity plays an important role in prevention of leprosy. Cell-mediated immunity plays a vital role in the control of disease. People with low CMI, that is lepromatous type of leprosy, have poor prognosis than tubercular type. So, CMI or cell-mediated immunity. Humoral immune response, antibody has minor role in the disease control as Mycobacterium leprae is intracellular. Now, what are the complications? There may be two types of complications. One is deformity, another is allergic response. So we'll go on separately. 25% of the untreated case develop deformities. So why deformities develop? Because leprosy can involve any organ or any part of our body. So nerve injury, muscle weakness or paralysis due to the sensory neural loss or due to motor loss. So muscle weakness and paralysis, disease process, there may be facial deformity or loss of eyebrows and also the saddle nose deformity. Saddle nose deformity because nasal bone is destroyed by leprosy. So the bridge of the nose is depressed and that is saddle nose deformity. That is another type of deformity. There may be infection or injury leading to ulcers. Why there is more chance of injury that lead to ulcer. So this is the causes of deformity. Common deformity, leonine face, sagging of face or saddle nose deformity, eyebrow, eyelashes, corneal opacity and ulcers. There may be claw hand due to loss of which nerve? Which nerve function leads to the claw hand? Ulnar nerve. So that leads to claw hand, and if it is radial nerve, it leads to wrist drop. Foot drop due to the posterior tibial nerve, clawing of toes, inversion of foot and plantar ulcer. So these are deformities. Saddle nose deformity in the picture A, and there is a bony deformity in the small picture B, and corneal opacity in the left eye. Due to these are the common complications of lepromatous leprosy. The most cases are lepromatous leprosy. Now lepra reactions. Lepra reaction you should read because it also comes as short note. There are two types of lepra reaction. One is type 1 and another is type 2. Type 1 is reversal reaction or lepra reaction. Type 2 is erythema nodosum leprosum. And lepromin test, early reaction is Fernandez and late reaction is Mitsuda reaction. We'll come in details. So this is lepra reaction 1 and lepra reaction 2. So Mantoux test we have done in tuberculosis, that is also type 4 delayed hypersensitivity. Here lepra reaction type 1 is type 4 delayed hypersensitivity reaction. Lepra reaction type 2 is immune complex mediated or type 3 reaction. In which type of patient we will see the lepra reactions? So in case of borderline leprosy, we will more see the lepra reaction type 1. And lepromatous variety, either it is a borderline lepromatous or lepromatous type, we will see the lepra reaction type 2. So how it manifests? Lepra reaction, how will you know the patient has presented with lepra reaction? Patient may be treated, may be untreated. That may present with lepra reaction. Directly, without other features, clinical features we have described, they may present with lepra reaction also initially. So, inflammation of the previous lesion, new skin lesion and neuritis. This is the lepra reaction type 1. There may be inflammation of the previous lesion and new skin lesion appearing, and there is involvement of nerve. That is lepra reaction type 1. And in lepra reaction type 2, there may be painful erythematous papules which become nodular, called erythema nodosum leprosum, ENL. Now, when it can occur? It can occur in type 1 can occur before treatment, progress. So when it appears, you may think of that it was borderline type, but it was going towards the lepromatous type. So if it occurs before treatment, progress towards lepromatous type, so it is a downgrading reaction. If it occurs after treatment, patient had already the treatment, then it presented with type 1 lepra reaction, then it is progress toward tubercular type. So this part is important. If it occurs before treatment, lepra reaction 1, then you downgrade to borderline lepromatous, 2 lepromatous. And if it is occurs after treatment, it is already patient has been treated with anti-leprosy drug, then it is tubercular type, that is reversal reaction. And lepra reaction type 2 usually occurs following the start of chemotherapy. So it erythema nodosum leprosum or type 2 reaction usually occurs after the chemotherapy. Now, what is the underlying response? What is the role of T helper cell? In T helper cell, 1 predominates in lepra 1. So, interferon gamma and interleukin 2, they produce interferon gamma, interleukin 2, and in lepra reaction 2, T helper cell type 2 predominates, leading to IL-6, IL-8, and tumor necrosis factor alpha plays a central role. Other organs usually not affected, but in case of type 2 reaction, eye, testes and kidney are affected. Can anybody tell what are the interleukins which are called inflammatory leukins or pyrogenic interleukins? Inflammatory, which interleukins are inflammatory interleukins? 1, 6 and 12 are commonly included in the inflammatory interleukins. So that lead to an increase in the inflammation. If you go to the pathogenesis of any fever, there will be rise in these 3 interleukins. 1, 6, 12 are inflammatory interleukins. So here in 1, 2 in lepra type of reaction, that is an inflammatory reaction, there is interferon gamma and increase in the interleukin 2. Now, what is the treatment of lepra reaction? It is only glucocorticoid is the treatment of choice in lepra reaction 1 and lepra 2. Glucocorticoid, thalidomide, clofazimine and antipyretics, all used in lepra reaction 2. So, what is the finally lepra 1 and lepra 2? Lepra 1 is an inflammatory reaction. It may be downgrading or upgrading reaction, that is, it is a reversal reaction. And type 2 reaction is after treatment that presents with erythema nodosum leprosum. And the treatment almost similar. Epidemiology. What is the source of infection? Most important are lepromatous leprosy or borderline lepromatous. Asymptomatic case have a role in transmission. Tubercular leprosy do not transmit the infection efficiently. In OPD, you have touched a patient, you didn't know the patient had leprosy. Will it transmit to you? You have seen a patient in the OPD, later on it is diagnosed as, say, tubercular leprosy, a nerve thickening was there. Will it infect you for that short contact time? It is usually needs long contact time, 4 to 5 years. So only the household contacts are affected leprosy. Not just a small contact in OPD will lead to the infection. But in tuberculosis, if you see a tuberculosis patient who is sputum smear positive and untreated, you can get the disease. So whenever you are going to any medicine ward, chest ward, preferably you wear mask. Tuberculosis can spread. You don't know in the whether the patient has tuberculosis or not. If he has tuberculosis and if it is sputum positive, then what is the number of bacilli? In 10 to the power 4 bacilli per ml. So that is a very good source of infection. In leprosy, why I have mentioned, just casual contact with a leprosy patients will not give you infection. Now, what are the mode of transmission? One is nasal droplet, aerosol containing Mycobacterium leprae. Contact transmission, direct contact from person to person. Indirect contact with infected soil fomites. And direct dermal inoculation during tattooing. Leprosy is not highly communicable. Intimate and prolonged contact is necessary for the transmission of leprosy. Environmental factors, people of rural areas, moist soil, humidity and overcrowding are the factors that is for the communicability of the leprosy. Now these are the few programs you should know about this leprosy eradication program or leprosy. In 1992, WHO launched a campaign to eliminate leprosy as a public health problem by the year 2000. Goal is less than one new case per 10,000 population. India has achieved that. India has achieved that, the elimination of leprosy. Achieved the elimination status by December 2000. Global leprosy strategy, that is 2016 to 20, launched by WHO in 2016, aims at reducing disability among the children by 2020. That was global leprosy strategy. Now, once leprosy was worldwide distribution, now almost exclusively confined to India. So, new leprosy cases are seen in India only. As on of 31st March, 90,709 cases are on record in India. 5 states or United Territory has reported prevalence above the elimination cutoff of 1 per 10,000. Now, laboratory diagnosis. This is very important because laboratory diagnosis. Now, any idea what is the, you already had a Jerenstein class in practical. So, what is the most common test to be done for diagnosing leprosy is Jerenstein stain or acid-fast staining, because it is also an acid-fast bacilli. But what is the difference with tuberculosis? There we use 20% or 25% acid. Here it is less acid-fast. We use 5% of the sulfuric acid. So 5% H2SO4, that is the main difference between the Jerenstein. So what is the commonest method of diagnosing? Is Mears microscopy. Now, what specimen will you take? For tuberculosis, we usually take sputum. So, what is the specimen you will take in case of leprosy? Anybody? What is the sample you will take for diagnosing leprosy? It is basically skin lesion or nerve lesion. So what you have to take is a slit skin smear. Slit skin smear. What is slit skin smear? We slit the superficial skin and take the secretion to stain with acid-fast stain. The procedure is almost same. You have to heat during using carbol-14 because it has also got mycolic acid. For penetration, it will need to have and heat the carbol-14. Then it is decoloration with 5% sulfuric acid, and it is counterstained by 4. So, what are the 6 samples? At least you take 6 samples. What are the 6 samples? What are the sites of 6 samples you need to collect? Initially, I mentioned leprosy prefers the cold positions of our body. So even if the skin lesion, you take 4 lesion from the side of the margin, because don't take the central part, slit skin smear from the advancing margin, because there is central clearing. So from the lesion you take 4 samples, and you at least take 2 samples from both the ear lobule. Both the ear lobule, if there is no lesion in the ear lobule or nasal symptoms, you have to take another samples other than skin lesion. You have to take sample from the ear lobule, this part of the ear lobule, and also from the nasal mucosa. So these are the at least 6 samples need to be taken, and 6 slit skin smear, one from the ear lobule and nasal mucosa by nasal blowing or scraping, and 4 from the skin. Here the mention the site, but the lesion may be in the different site. So you have to take, other than this, you have to take from the site of lesion. And where will you take the sample? From the advancing margin of the hypopigmented patch. So advancing margin. So nasal specimen preferably from the early morning mucous material, otherwise nasal scraping may be done. So before taking nasal scraping, you should protect yourself also, because nasal droplet infection is one mode of spread of leprosy. So less acid first, it is 10 by Jean-Nielsen 10 technique, 5% sulfuric acid. Now what is the difference between the, if you see it in the microscope, how will you differentiate if it is not told that it is a case of sputum smear or it is a case of slit skin smear? First point, how will you differentiate? In case of sputum, you will get pus cell and epithelial cell like as in sputum. But skin, epithelial cells and macrophage you will see in the smear, and most of these bacilli are intracellular, within the macrophage. This is the first point of differentiating what is the mother specimen, whether it is a sputum or whether it is a slit skin smear. And there is another pattern that was in tuberculosis. It was slender and beaded pattern. Beaded means not the staining is not uniform, but there is no beaded pattern in leprosy. What is leprosy? Is red seagull-like bundles. Red seagull-like bundle, either arranged singly. These are all lepromatous leprobacilli. Leprobacilli, seagull-like bacilli, and there is viscous lepra cell or foamy cells in the smear. Now there is also a name of this seagull-like bundle. You remember the name globi. G-L-O-B-I, globi is called. So more groups, seagull-like bundles of acid-fast bacilli, formation of globi. How will you differentiate? It is a live bacilli or it is dead bacilli. So live bacilli is usually uniformly stained with parallel side, rounded end, and length is 5 times the width. So this is the features of live bacilli. Dead bacilli, less uniformly stained, fragmented and granular part. How will you differentiate the live bacilli and dead bacilli? What is the importance of live bacilli? Why we want to know it is a live bacilli or dead bacilli? It may be before treatment, the test was done. It may be test during treatment. So we need to know the response to treatment. Now this is the grading. Grading of the slit skin smear. If it is 1 to 10 bacilli in 100 oil immersion field, it is 1 plus. It is 1 to 10 bacilli in 10 oil immersion field, it is 2 plus. 1 to 10 bacilli per oil immersion field is 3 plus. So 10 to 100 bacilli in per oil immersion field is 4 plus, and 100 to 1000 bacilli per oil immersion field is 5 plus, and more than 1000 bacilli, or that is called grade 6. Now, even if you don't count, how can say it is a grade 6 smear if there is globi? Globi means cluster of acid fast bacilli is there. That is called a grade 6 smear. Now, these are the two index. Remember, they can come as short note, that is bacteriological index and morphological index. What bacteriological index calculates? It calculates all acid fast bacilli, whether it is a live or dead. So bacteriological index includes both live and dead per oil immersion field. Morphological index is percentage of uniformly stained bacilli out of total number of bacilli counted. So what is a better index for monitoring treatment? Morphological index is a better index for monitoring the treatment of leprosy. Solid fragmented granular rod percentage. It is similar to morphological index. This is a new term. Solid fragmented granular rod percentage. A better picture of bacterial morphology. Sometimes it is called more sensitive indicator of monitoring. In some of the books it is included in the morphological index. Some of the book it is given as separate small fragmented granular rod percentage. So how will you calculate bacteriological index? You add all the pluses. Particular field is 1 plus, 2 plus or 6 plus. You add all the pluses and divide by the number of fields, number of smears you have. So number of smears you have checked. So at least 6 smears you have to check. So calculate the number of pluses. If it is a 4 plus, 1 smear is 6 plus, 1 is 5 plus, then add their pluses and divide by the number of smears you have examined. That is the total bacteriological index, and morphological index is percentage of solid fragmented granular bacilli divided by uniformly stained bacilli out of total number of counted. So what is morphological index? Uniform stained bacilli divided by uniformly stained bacilli divided by total number of bacilli found. Now, in all bacteria we have talked about culture. So why we didn't talk about culture in case of leprosy? There is no still artificial media where you can culture leprosy. There is no artificial media, so leprosy doesn't follow, Mycobacterium leprae doesn't follow the Koch's postulate. So it cannot be cultured. Still there no media, no artificial media to culture Mycobacterium leprae. There are experiments going on. There are many scientific studies where they said they are developing media for culturing Mycobacterium leprae, but till date no official or no recognized culture media for culturing Leprometas leprosi. Why it cannot be cultured? What is the fault? First is generation time. There is a long generation time of 12 to 13 days. Next, G plus C, guanine cytosine index is lower than Mycobacterium tuberculosis. These are the two common causes why the Mycobacterium leprae cannot be cultured. So if it is asked which bacteria does not follow Koch's postulate, Mycobacterium leprae is one of the examples where it does not follow the Koch's postulate. Now, if it is not cultivated with artificial media, can it be grown? Yes, it can be grown in either into the foot pad of mice, keeping at 20 degrees centigrade for 6 to 9 months. You have to inoculate with Leprobacilli foot pad of mice and keep it for 6 to 9 months at 20 degrees centigrade for growing of Leprobacilli. Other animals, 9 branded armadillo. Remember these two names. For animal inoculation, one is foot pad of mice, another is 9 branded armadillo. These are two animals where you can cultivate Mycobacterium leprae. What is advantage of mouse foot pad cultivation? 10 times more sensitive than microscopy, detecting drug resistance and evaluating potency of the drug, detects viability of the bacilli. How it detects the viability? Dead bacilli will not multiply. So here only the live bacilli can grow. So only the live bacilli can grow in the foot pad of mice. That is difference the viability of the bacilli. What is the disadvantage? They are time consuming 6 to 9 months and there are few ethical issues in animal experiments. Antibody detection, just for knowing, it is not regularly done. FLA, ABS, fluorescent leprosy antibody absorption test to identify the subclinical case, 92% sensitive and 100% specific. ELISA for detecting IgM antibody against phenolic glycolipid 1. Lepromin test. That is another question for short note. What is lepromin test? What it detects? Lepromin test usually detects the cell-mediated immunity. It detects the cell-mediated immunity. If it is positive, that means the cell-mediated immunity in the patient. Also the delayed hypersensitivity type of reaction against the lepra antigen. So lepromin antigen injected intradermally to forearm and reading is taken on 2 occasions. Mantoux test. When the reading is taken, Mantoux test is a similar test in Mycobacterium tuberculosis. Reading is taken after. When the reading is taken after Mantoux test, Mantoux test reading is taken after 48 to 72 hours. What is the positive reaction in Mantoux test when you call it positive? You have to look for induration, developmental swelling after 5 tuberculin unit of unified protein derivative. So you need to look for the induration. What is the size of the induration above which you will call it positive? It is 10 millimeter. So you have to measure after giving the 5 tuberculin unit of purified protein derivative. You have to measure after 48 to 72 hours. And induration should be more than 10 millimeter in tuberculosis. Why I have mentioned? Because this test is similar, but the reading is bit different. So that is induration, not the erythema or the redness of the skin after the injection. Only induration matters. So only if it is more than 10 millimeter in induration, then the Mantoux test is positive, but not the erythematous or any redness of the skin. Now, here lepromin test is read after 2 occasions, not single, 2 occasions. When? After 48 hours, after 21 days. So what is the 48 hours? Similar to Mantoux test, in duration more than 10 millimeter, correspond to delayed type of hypersensitivity reaction and indicate past exposure to Mycobacterium leprae bacilli. So 48 hours, it is called early or Fernandez reaction. These 3 can anytime come as short note. One is pure neuritic type of leprosy, one is lepromatous multibacillary, paucibacillary leprosy, and one is this lepromin test, and also the lepra reaction. And how will you lab diagnose the Mycobacterium leprae? These 5 points you should know after reading leprosy. So at 48 hours, in duration more than 10 millimeter, corresponds to delayed type of hypersensitivity. It is a type 4 hypersensitivity. And after 21 days, late or mixed to the reaction, a nodule of more than 5 millimeter diameter and which subsequently ulcerates. If positive, it shows patient cell-mediated immunity arm is intact. Cell-mediated immunity arm is intact. If it is negative, absence of cell-mediated immunity. So in duration more than 10 millimeter is after 48 hours, early or Fernandez reaction, late or Mitsuda reaction. Treatment of leprosy. What are the three drugs commonly used in treatment of leprosy? Commonest is dapsone, then it is rifampicin and clofazimine. You know rifampicin and clofazimine is also used in treatment of tuberculosis also. Alternate drugs, ethionamide, quinolone, minocycline and clarithromycin. So first you know three drugs, dapsone, rifampicin and clofazimine. Now this is WHO regime. According to 2018, WHO always recommend a three-drug regime, dapsone, clofazimine for all leprosy patients. Dapsone 100 mg daily, self-administered, rifampicin 600 mg once a month under supervision, clofazimine once a month under supervision 300 mg and 50 mg daily. Then what is regime? So you ask the patient to take dapsone daily, dapsone 100 mg daily, clofazimine 50 mg daily. He will take at home, but he will come to the center and take supervised rifampicin 600 mg once a month and clofazimine 300 mg once a month. So this is the treatment protocol. Dapsone, rifampicin, clofazimine. Now what is the difference? Then what is the difference between paucibacillary and multibacillary? So that is in the duration of treatment. For paucibacillary treatment, you have to treat for 6 months, and for multibacillary, you have to treat for 12 months. So the treatment regime is same for paucibacillary and multibacillary. There is three drugs, dapsone, rifampicin and clofazimine. But paucibacillary, you need to continue for 6 months, and in case of multibacillary, you have to continue for 12 months. Now, how long you need to follow up? For paucibacillary, you need to follow up for 2 years, and for 5 years, multibacillary. How will you follow up? Any idea? Again, slit skin smear. Slit skin smear, that's why there lies the importance of morphological index. That is the live bacilli, differentiating between live bacilli and dead bacilli. Now, how you can prevent leprosy? By active case finding and effective treatment of the case, BCG vaccine has no role. MIP vaccine, killed leprosy vaccine developed in India, Mycobacterium indica sparingly, these are not used. So you just know there is no suitable or no vaccine at present for leprosy. Chemoprophylaxis, in which you will give chemoprophylaxis. Household contacts, the risk of household contacts of tuberculosis patient, but not for lepromatous patient is not recommended. Hospitalized patient need not be isolated as transmission requires prolonged contact. TB patient need to be isolated. How long the TB patient need to be isolated? If a patient is admitted without the diagnosis of TB, patient has been diagnosed with tuberculosis, how long will you isolate that patient? You are going to wards, so you should know between when you are going to ward, you know how long you will isolate a TB patient after starting of treatment. Treatment, not before starting of treatment. After starting of treatment, how long a TB patient needs to be isolated? It is for 2 weeks. At least for 14 days. You need to isolate the TB patient in spite of starting the treatment. So, but in leprosy, isolation is not required. Generation time, 12 to 13 days I have already told. And what is lepromatous leprosy? This is 12 to 13 days next. Lepromatous leprosy, which is correct? So it is multibacillary. Any question from your side? Have you seen the taking of slit skin smear? If you have not seen, you can go through some YouTube videos are there for how will you collect the slit skin smear and how it is stained. You know, the staining is same as Jerem stain, but collection of slit skin smear, I have not included the video because that would have been long. So slit skin smear, first 3 points, you need to maintain a bloodless film, and as there is already anesthetic patches are there, you need not give local anesthesia. Take the just slit the superficial skin and take the secretion and heat dry and then stain with Jaden stain.
Okay, and this is probably a revision topic. I have taught this in this batch previously before the publication of supplementary examination results. So this is a very important topic and frequently asked in your internal assessment as well as theory examination, theory final examination. So mediators of acute inflammation is mostly come as a long question, but so among the type of mediators of acute inflammation, there are two types of mediators. One is cell-derived mediator, another is plasma-derived mediator. From the last row, is it visible? Last row student, is it visible? The board? Okay, so this is the two cell-derived mediator, two types of mediator. One is cell-derived mediator, another is plasma protein-derived mediator. The most important mediators of acute inflammation are cell-derived mediator. They are specialized cells in our body, and those cells with exposure to the insulting agent as acute inflammation, they release some kind of mediator or chemicals that help to progress the inflammation cascade or inflammation process. Some are beneficial to the system and some are detrimental to our system. Okay, so from the cell-derived mediator, few are mediators that are released from pre-formed granules. So few cells, they contains granules from their origin, and after exposure to the insulting agent, the mediators, they release from the pre-formed granules of those cells, namely basophils, okay, namely mast cells, okay. But other cell-derived mediators of acute inflammation, okay, they are newly synthesized from the cell after initiation of inflammation, namely eicosanoids, okay, namely thromboxane or prostaglandins. So this is an exhaustive list of cell-derived mediator. The preformed mediators in secretory granules, the mediators are histamine and serotonin, and their source are mast cell, basophil, platelets, okay. And among the newly synthesized mediators, there are prostaglandins, leukotrienes, platelet activating factor, reactive oxygen species, nitric oxide, cytokines, and neuropeptides. So these mediators, they are all newly synthesized after the initiation of inflammation, okay. And their cells of origin are leukocyte, mast cell, as well as endothelial cell, few nitric oxide, they come from macrophages and endothelial cell, nerve fibers, lymphocyte, etc. Okay, so there are variety of cell-derived mediators, and mostly they are newly synthesized, and few are they secreted from preformed granules. And coming to the plasma-derived mediators, those are very less in number, and those comprise, they are derived from mainly liver. So you know, our liver is the metabolic factory of our body, and liver is the chief organ to produce plasma protein. Okay, plasma protein, albumin, globulin, kinin. Okay, the proteins of coagulation systems. So the liver major source, the two plasma derived mediators, the source of is liver, those are complement and kinin system or coagulation system. So among the complement system, these are byproduct of the complement system, C3A, C5A, C3B and C5B to 9. These are called membrane attack complex, and C3A, 5A and 3B are called anaphylatoxin. So these are the byproducts of an complement system. Both they are released due to activation of complement system, either due to complement pathway activation in classical pathway, or in alternative pathway, or mannose binding pathway, or lectin pathway. But these are the byproducts, and they use as an anaphylatoxin. So they initiate and they progress the phenomenon called anaphylaxis. Okay, the allergic reaction. And the factor 12 kininogen, kinin system and coagulation system, they are responsible for the microvasculature clot and fibrinolysis, as well as clot dissolution. Okay, so coming to the details of the mediators and their respective functions. The most important hallmark of inflammation. What are the hallmarks of inflammation? Increase in vascular permeability, vasodilatation, okay, and fever and pain, color, dolor, rubor and tumor. So the swelling, the redness, okay, and the pain, these are the symptoms that the patient will come to you with these symptoms whenever he or she has been suffered with any sort of acute inflammation. So their main functions of cell-derived or plasma-derived mediators are, the most important is vasodilatation. Without vasodilatation, the acute inflammation doesn't initiate. Okay, the process of acute inflammation starts with vasodilatation. So the most potent vasodilators are prostaglandin, nitric oxide and histamine. Is this list visible from the last row? Is it visible from the last row? Say yes or no. Okay, next, another important hallmark of inflammation is increase in vascular permeability, and the mediators are histamine, serotonin, C3A, C5A, bradykinin, leukotriene, C4, D4 and E4, platelet activating factor and substance P. So here the action is unified, okay, increase vascular permeability or vasodilatation, but the action is attributed by many chemicals, by many mediators. So these are actually converging type of action, that varieties of chemical mediators, they usually recruited to do a single type of activity, namely vasodilatation, namely increase in vascular permeability, etc. Next, leukocyte recruitment and activation, those are attributed by the mediator of TNF, interleukin 1, chemokines, C3A, C5A, leukotriene B4, etc. Okay? So, leukocyte recruitment and activation, the rolling of leukocyte through the endothelial cell, leukocyte recruitment to the site of injury, then the leukocyte, they transmigrate from the vessel wall to the extracellular space, okay, with help of various ligands. So leukocyte activation and recruitment, these are mediated by various chemokines and tumor necrosis factor interleukin 1. Fever. Fever is initiated by interleukin 1 and tumor necrosis factor. Pain is initiated by prostaglandin, bradykinin, neuropeptide. And tissue damage is initiated by lysosomal enzymes of leukocyte, namely neutrophils, reactive oxygen species, and nitric oxide. In this type of mediators, okay, this nitric oxide, we have seen there is a prefix called Rx. Nitric oxide, we can see that its prefix is Rx. Prostaglandins is also Rx. So there are various chemical mediators of acute inflammation. Those have therapeutic effect in our body, like acute myocardial infarction or acute hypertensive emergency. Okay, in these cases, nitric oxide, they are used as therapeutic agent, as because of the reason nitric oxide is a very potent and ultra short acting vasodilator. So whenever a patient comes to you with acute myocardial infarction or hypertensive encephalopathy or hypertensive crisis, nitric oxide can be used as therapy. And another therapeutic agent is NSAID, non-steroidal anti-inflammatory drugs, okay, like aspirin, combiflam, acetaminophen, ibuprofen, brufen, this type of drug. They act on to inhibit the prostaglandin. So the pain sensation of the patient will be less. Okay. So vasodilatation, increased vascular permeability, leukocyte recruitment and activation, fever, pain and tissue damage. These are the major actions of the mediators. And I told you earlier that these mediators have a converging type of action. 4 to 5 mediator, they usually act on a multiple effect and they usually impart to the cell as a converging effect, like chain reaction. One chemical mediator, they have been activated. This activation of one chemical, they release the activation and release of subsequent other chemical mediators, like chain reaction. Okay. Next. So coming to the most important chemical mediators, vasoactive amine, histamine and serotonin. Among the cell-derived mediators, the most important vasoactive amine is histamine and serotonin, and they are formed from preformed granules of basophil, mast cell, etc. So, what are the action of histamine? Like, they are involved in type 1 hypersensitivity reaction, the allergic reaction. I have taught you the hypersensitivity, types of hypersensitivity. The type 1 hypersensitivity is IgE mediated, okay? So, whenever there is exposure of any allergen in our body, the antigen, they bind on the expressed IgE on the surface of the basophil and mast cell, okay? So, after the attachment of antigen to the antigen binding limb of the antibody, namely IgE, immunoglobulin E, these preformed granules of the mast cell and basophil, they have been burst to release these granule bound mediators, namely histamine, serotonin, platelet activating factor and other mediator, etc. Okay. Next important cell mediated cell derived mediator is cytokines. There are extensive list of cytokines, and cytokines have a variety of function. Okay, they are effect in immune system, they have their effect in hematopoiesis, they have their effect in acute inflammation. Okay, so interleukin 1, interleukin 2, interleukin 3, interleukin 4, interleukin 5, interleukin 6, interferon alpha, interferon beta and interferon gamma. These are the cytokines, okay? These are the list of cytokines. Other cytokines are those involved in hematopoiesis are GCSF, GMCSF, that is granulocyte colony stimulating factor, granulocyte monocyte colony stimulating factor, monocyte colony stimulating factor, okay? And last but not the least is tumor necrosis factor alpha and tumor necrosis factor beta. So I have told you these have variety of function, okay? Immune system, hematopoietic system, non-specific defense, etc. So secretion by individual cells like endothelial cells, like leukocytes, like macrophages, and these cytokines, signal peptide or signal protein, they are released, they accentuate or accelerate to other chemicals from secreted and released from the other cells, okay, like a chain reaction. The cascade never stops until and unless the inflammation going to an end. So these are effect are in immune system, hematopoietic system, non-specific defense, etc. Among these, interleukin 1, interleukin 6 and tumor necrosis factor alpha, TNF alpha, is important in our curriculum as well as common day practice. So what are their effect? They have multiple effect, endothelial effect, they have systemic effect, they have fibroblastic effect and leukocytic effect. So most important cytokines are interleukin 1 and tumor necrosis factor alpha, bacterial product, immune complex, toxins, physical injury and other cytokines. So other cytokines, they are also initiator mechanism of release of another cytokine. Activation of macrophages and other cell. So the activation of macrophages is the pivotal event for release of cytokines, and the most important cytokines are interleukin 1 and TNF or tumor necrosis factor. So endothelial effect, coming to the endothelial effect, increased leukocyte adherence, increased prostaglandin synthesis or prostacyclin synthesis, increased procoagulant activity, decreased anticoagulant activity, and increase in secretion of other cytokines like interleukin 1, interleukin 8, interleukin 6. Okay. So endothelial effect, what are the importance of increased procoagulant activity and decreasing anticoagulant activity? So we know among the hallmarks of acute inflammation that vascular stasis and slowing of blood flow is very important for initial phases of inflammation. So increased procoagulant activity and decreased anticoagulant activity, they are responsible for vascular stasis or slowing of blood within the vessel and allowance of the microclot to form along the vessel wall. Okay, so the endothelial injury and the vascular insult will occur, and then the other events of the inflammation occurs. Coming to the systemic effect, very important, fever. Okay, interleukin 1, interleukin 6, very important to cause the fever, systemic symptoms like fever, like altering the thermostat mechanism in our hypothalamus. Okay, increase sleep, decrease appetite, very important. Decrease appetite in systemic inflammation attributed by the cytokines named by tumor necrosis factor. Okay, so fever is mediated by interleukin 1 chiefly, and decreased appetite or cachexia is mediated by tumor necrosis factor TNF alpha. So, and fibroblastic effect, increased proliferation of the fibroblast, increased collagen synthesis, increased effect of collagenase, increased protease, and increased prostaglandin synthesis. And leukocytic effect, increased cytokine secretion. So this is a chain reaction. One cytokines, they facilitate to release of other cytokines, and all the cytokines, they have cumulative effect in our body, like systemic effect, fibroblastic effect, endothelial effect, and leukocytic effect. Okay, everybody clear? Now this is the pain pathway, dorsal root ganglia. Okay, nucleus solitarius, medulla oblongata, and interleukin 1 and tumor necrosis factor alpha. So antipyretic, acetyl salicylic acid or paracetamol, they act on this pathway. So from arachidonic acid, prostaglandin E2 cannot be formed. Okay. Now chemokines, important, C3A, C5A, chemokines for leukocyte activation and recruitment to the site of injury. Okay, this is the vessel wall endothelial cell and this is the neutrophil. They have ligand in their surface as well as they have ligand in the endothelial surface, and after when the leukocyte attached to their respective ligand on the endothelial surface, they are release of chemokines. They action on fibrin and fibronectin as extracellular matrix, and this leukocyte eventually find gap from this endothelial cell junction, and this leukocyte they come to the extracellular space to combat the action of inflammation. Name of the ligand, integrin, high affinity state, integrin ligand, ICAM1. Okay, so these are all chemokines. Chemokines are released from neutrophil or leukocyte. Okay. Now, the most important cell-derived mediator, newly synthesis, often asked as short note, are icosanoids. What are icosanoids? What does it mean, the word icosanoid? Icosa means 20. Okay. In Greek, icosa means 20. So, icosanoids is the molecules that are derived from 20 carbon molecule, namely arachidonic acid. So, arachidonic acid is a 20 carbon molecule. So, in Greek literature, 20 is named as icosa. So, so the molecules they are derived from arachidonic acid are collectively known as icosanoids. Okay. So, what are their formation? How they form? Cell-derived cell membrane phospholipid. By the action of phospholipase, the formation of arachidonic acid occur. Okay. Cell have a lipid bilayer, protein lipid bilayer. Taito. So, from the phospholipid of the cell membrane, from cell membrane phospholipid, and by the action of phospholipase enzyme, the cell membrane phospholipids are split into arachidonic acid. And after the formation of arachidonic acid, there are two important enzymes that acts on arachidonic acid to help in formation of various terminal molecule named as icosanoids. Okay, what are those enzymes? One is cyclooxygenase or COX. Another is 5-lipoxygenase. Okay, so from arachidonic acid, upon action of cyclooxygenase, two important molecules they are formed. One is prostaglandin, another is thromboxane. Okay, prostaglandin and thromboxane, those are antagonistic type of action. Okay, so prostaglandin, prostacyclin, these are vasodilator. Okay, but on the contrary, thromboxane, these are vasoconstriction effect. Okay, vasodilatation effect are attributed by prostaglandin and prostacyclin, but thromboxane A2, those have vasoconstrictor effect. Procoagulant effect is attributed by thromboxane A2, but anticoagulant effect is attributed by prostaglandin and prostacyclin. Okay, so starting from the cell membrane phospholipid, action of the phospholipase splits the cell membrane phospholipid into arachidonic acid, the 20 carbon molecule. From the arachidonic acid, two important enzymes action occurs. One is cyclooxygenase or COX, another is 5-lipoxygenase. On action of cyclooxygenase or COX, the two stream of antagonistic effect molecules are formed. One set is prostaglandins, another set is thromboxane. Prostaglandins and thromboxane have antagonistic type of effect. One has, prostaglandin has vasodilator effect. Prostaglandin has anticoagulant effect, but thromboxane A2 has vasoconstrictor effect. Thromboxane A2 has procoagulant effect. Okay, so this is the basic. And from the action of 5-lipoxygenase, the molecule that is formed is 5-hydroxy tetra icosanoic acid. Okay, so from 5-hydroxy icosanoic acid, with the action of 12-lipoxygenase, the molecules are formed, namely as leukotrienes. Okay, leukotrienes C4, leukotrienes D4, leukotrienes E4, etc. So leukotrienes have the effect of vasodilatation, bronchial muscle constriction, increased vascular permeability, etc. Okay, so icosanoid is very important to come as a short note. Okay, prostacyclin, the action of prostacyclin, vasodilatation and inhibit platelet aggregation. I told you repeatedly. Thromboxane A2 cause vasoconstriction and promote platelet aggregation. Other prostaglandins, namely PGD2, PGE2, these are also involved in prostaglandin. Other prostaglandin, they are also vasodilator. Okay, and by the action of 5-lipoxygenase, the chemicals formed are lipoxin A4, lipoxin B4, and leukotriene. Most important. Okay, leukotriene B4, leukotriene C4, leukotriene D4. These are all vasoconstrictor and increasing vascular permeability and smooth muscle constriction. So the patient of acute attack of bronchial asthma has increased action of leukotriene C4 in their throat or in their bronchioles. So the therapy involves the agents which antagonize that the action of leukotriene, that is named as Ziluton. Okay, that is antagonistic effect on leukotriene. So in bronchial asthma, the action of leukotriene, if inhibited by some agent, the bronchial constriction or the spasm of the bronchioles is lessened to some extent. And other therapeutic agents, what are the therapeutic agents that act as anti-inflammatory drug? That is steroid. Steroid actions on inhibition of phospholipase. So from the cell membrane phospholipid, the arachidonic acid fails to form. Okay. Name therapeutic agents are cyclooxygenase enzyme inhibitor, COX inhibitor, the analgesic. Okay, COX inhibitor, etoricoxib, celecoxib, COX1, COX2. Some agents, they inhibit cyclooxygenase 1 selectively. Some agents, they globally inhibit cyclooxygenase. So these are all have therapeutic effect in our body. So inhibition of any of these enzyme in this cascade, they help to reduce the systemic effects of inflammation. Everybody clear? হ্যাঁ না উত্তর নেই কোনো, খালি চুপ করে তাকিয়ে থাকে। আচ্ছা, next is reactive oxygen species. Very important. Our free radicals in our body, superoxide, hydroxyl ion, superoxide ion. Okay, so these are, so what are the reactive oxygen species? How they form? Oxygen by donating electron, the formation of superoxide. Superoxide after receiving electron formed as hydrogen peroxide. Hydrogen peroxide after receiving electron, they form hydroxyl radical. Okay, so superoxide ion, hydroxyl radicals, these are free oxygen species or reactive oxygen species. They initiate cell damage. Okay, and the antioxidant, the natural antioxidant mechanism in our body, the scavenger system of our body, that helps in eliminating these reactive oxygen species. There are few enzymes. What are the important enzymes? Glutathione peroxidase, catalase, and superoxide dismutase. So this is the formation of the free oxygen radical or reactive oxygen species, and these enzymes, namely superoxide dismutase, catalase, and glutathione peroxidase, these are natural antioxidants. They are help in dissolution of reactive oxygen species. Okay. Now, nitric oxide, I told you, the most potent vasodilator, ultra short acting vasodilator. So, the source of nitric oxide is endothelial cell. Okay. So, this is also important mediators of acute inflammation. And how they help? They help vasodilatation, vascular smooth muscle relaxation, reduce leukocyte adhesion, and reduce adhesion of the platelets. So, there is increased vascular permeability and vasodilatation. Thus they help in acute inflammation. Nitric oxide, it also has therapeutic effect, where I told you earlier. So, nitric oxide as transmitter substance, not important for you. Now, leukocytic lysosomal enzyme or neutrophilic enzyme. Neutrophil has two types of granules, primary granules and secondary granules. Neutrophil has two types of granules. Okay, neutrophil has a granulocyte. So they have granules in their cytoplasm. The nucleus is 3 to 5 lobed. Okay, and the granules, those are also called azirophilic granules. One are primary granules, one are secondary granules. Few have global action, few have specific bactericidal action. So the enzymes, they are secreted in primary granules are myeloperoxidase, azurosidine, cathepsin, etc. This is multi-lobe nucleus, microscopic examination, microscopic picture, azirophilic granules. Okay, azirophilic granules. Granules in the cytoplasm. And this is, এটা কি মাইক্রোস্কোপে দেখা যাচ্ছে এই ছবিটা? Which microscope? Electron microscope. Okay. So these are the primary granules, the bigger one, and these are the short one are secondary granules, and they are responsible for release of leukocytic enzymes or leukocytic lysosomal enzymes, namely মাঝে মাঝে এটা কাজ করছে না রে বাবু। So azirophilic granules, also known as primary granules, I told you neutrophil elastase, cathepsin G, protease, azurosidine, and myeloperoxidase. These have global bactericidal effect. Okay, and also important thing is NET or neutrophil extracellular trap, that trap bacteria and neutrophil elastase. And specific and tertiary granules are namely lactoferrin, lipocalcin, and lysozyme. Okay. So these leukocytic lysosomal enzymes, they have bactericidal effect. Okay, and they kill the bacteria by digestion and by the action of the specific lysosomal enzyme. Okay, by the mechanism of phagocytosis. Okay. Neuropeptides and platelet activating factors. Neuropeptides very important in pain pathway. Okay, dorsal root ganglia. Okay, substance P is important neuropeptide, and it is important mediator for sensation of pain. So the pain or the dollar is one of the important hallmark of acute inflammation, and it is mediated by substance P. So most important are cell-derived mediator. Now coming to the end, plasma-derived mediator. The plasma-derived mediator are mostly complement factor and kinin or coagulation factor. Coagulation, this topic will be taught you later in your syllabus of second internal assessment, and complement, this will be taught in your microbiology. Okay, but the byproduct of complement system is important in acute inflammation. How? These are the byproducts and these are their effects: C3A, C4A, and C5A. Among the C5A, this is the master anaphylatoxin, and this has the maximum effect of contraction of smooth muscles, increased permeability of blood vessels, degranulation of basophils, and chemotaxis and release of free oxygen radical and lysosomal enzyme. So these are the byproduct of complement C3A, C4A, and C5A. These are collectively known as anaphylatoxin, as they initiate the process of anaphylaxis. Among the C3A, C4A, C5A, C5A is the most potent one to mediate various action like increasing vascular permeability, vasoconstriction, and superoxide free radical mediated injury, chemotaxis, degranulation of basophil, etc. So this is the membrane attack complex. Complement system will be taught by microbiology teachers in very detail, the 2 to 3 pathway, their byproduct, their utility, complement deficiency, complement enzyme deficiency, what are the important inborn disease that patient will have due to deficiency of complement system, that will be detailedly taught in your microbiology theory classes. And the last is kinin system. এটা একটু নষ্ট হয়ে গেছে নাকি গরমে? So coagulation and kinin system, very important, but will be taught in details in your second internal assessment. Coagulation, just know that there is two pathway. One is intrinsic pathway, another is extrinsic pathway. Intrinsic pathway and extrinsic pathway both converge to a common pathway. They are 10 to 12 coagulation factor, and they help in our acute inflammation by formation of blood clot and dissolution of blood clot following the vascular stasis.